Hello, everybody. I'm back. Dr. K.K. Agarwal, President, Confederation of Medical Association of Asia and Oceania. And you are watching Med Talks with Dr. K.K. Agarwal, 160th non-stop episode on COVID-19. Let's have the headlines of the day. India has been recording less than 30,000 daily new cases continuously for the last 13 days. Almost 1,500 containment zones in Delhi have been decontained in the last 11 days, indicating a sharp drop in COVID-19 cases. The Health Ministry has planned a dry run in 4 states, Punjab, Assam, Andhra Pradesh, and Gujarat, before the rollout of the vaccine on December 28 and 29 to evaluate readiness for COVID immunization. The variant of concern 202012/01, the UK strain of the new virus, has been detected in 8 European countries, says the regional director of WHO Europe. And MedTalks and Heartcare Foundation of India has been talking about it and saying all the countries in the Europe where the spike, the second peak, is larger, broader, and earlier than the first week, is nothing but the new strain of the virus. Japan also has reported 5 cases of infection with the new UK variant. So is Singapore, so is Australia, and many other countries who are reporting it. Another new strain has been recorded in Nairobi, but that's not a significant strain because that is not causing spread so much. Before we go and introduce the new topic and the speaker of the day, let's have the ritual of washing our hand, which we concentrate every day. So S for Seedha, U for Ulta, M for Mutti, A for Angutha, N for Nakhun, and K for Kalai. Now we are ready to accept our guest. Let's have the topic of the day. As promised, we are bringing you the guests from our neighboring countries and also from all over the world to discuss the situation there. I have with me my special guest today, Dr. Prakash Buddhatoki, who is the Director, Curative Service Division of Ministry of Health and Population, Nepal. He is also the Treasurer of Nepal Medical Association. He is involved in the preparation of guideline, protocol, policy development regarding COVID-19 in Nepal. He is a master trainer in case investigation and contact tracing program, member of Incident Command System, ICS, and Hospital Preparedness for Emergencies, HOPE, in Nepal. And he also himself is a COVID warrior. He has successfully beaten COVID-19 infection in himself. Let's listen to him and then we will interact with him. Yes, Prakash.
Yeah, thank you, Dr. KK. Please show my PowerPoint. Because I'm just sharing the Nepal's experience. This is the till date, till today's data, because total PCR testing site in Nepal is the 80. Among the 80, government lab are 45 and the private lab are 35. And total PCR test done was more than 19 lakh. That means the nowadays, in the last 2 weeks, the average 6,750 test per day was going on. In the government, it is more than the 13 lakhs, and in the private, more than 5 lakhs. And in the calculation, per million, 65,311 tests are going on. Total PCR positive cases till now is 2,57,700, and total active cases are 6,749. That means 2.6% of the total infection. And the total discharge was 96.7% of the total infection. And total death till now is 1,819. That means 0.71% of the infection. And in home isolation, there is a 3,349, and in the institutional isolation, that means the isolation centers and the isolation hospital run by the government is 3,400. The total isolation beds are 19,527, and total quarantine beds are 52,716. Till date, in the ICU, there is a 228 patient, and in the ventilator is the 50 patient, and in quarantine there is a 369 infected patients are there. But in quarantine, they are not infected, they are waiting for the PCR test because they are coming from the outside, or they are in the close contact with the infected people. Next slide, please. And this is the just the diagrammatic presentation of the first slide. That's why please go to the next. And then this is the infection distribution all over the Nepal. That's why we saw in the southern belt of Nepal, there is a high infection rate is there. Next slide, please. And the upper one is the based on the district, because in Nepal there is a 77 district. In 77 district, only few districts are left as non-infected, and remaining all are the infected. And the lower one slide is total infection per district. Next slide, please. And this is by the province wise, because since few years we are exercising the federal system. That's why we have a 7 province. On the basis of province wise, there is a total case of infection, there is a total death, and everything where. And till now we are thinking that this is the cluster transmission. It's not the community transmission. Next slide, please. And this is the by age wise. That's why in 25 to 34 years, that is the active group, which generally works, migrate, and everything. There is a high infection rate. And the senior citizenships, they have a less infection rate. That's why I think we can say till now there is no community transmission, because once the community transmission is present, then there will be the more chances of infection in the senior citizenship, female population, and child population also. Next slide, please. And to know the community status of the infection, we have done National COVID-19 Sero Prevalence Survey. On that, we tested the antibody, and on the basis of that, so that who have symptoms, they are coming in the hospital and they are doing the test. But in the COVID, previously more than 91 to 95% infection were the symptomless. That's why we wanted to know the infection rate in the community, and we want to make the policy on the basis of that. That's why we have done the seroprevalence survey. Next, please. In the why total antibody for sero survey we did, because that we want to make the policy, and we want to make the next action plan, how to go ahead. That's why we are doing the antibody, and antibody also that based on the IgG and IgM both. And once the symptom appears after 1 week, then serially the antibody comes. That's why we are catching that point. Next slide, please. And this is the diagram for the test. Next. And this is the timing of sero survey in Nepal, because we have seen the maximum peak in the September. Next, please. And this is the by male and female, because generally the male have a high. And in seroprevalence, we have seen that 13.5%, those who don't have the sign and symptom, but they are staying in the community. They don't know they are the COVID positive also, because they already got infected and they became fine also. Next, please. And this is the seropositive by age group. Here also in 35 to 44 years age group, they have a highest antibody value because they are the migrant group. They can go out and they can take the infection and transmit the infection also. Next slide, please. And nowadays we are doing the next test also, antigen testing in hot spot area like in government hospital, in sabji mandi, like vegetable shops, in those places where the crowd is there. In there, we are doing the antigen testing, and we have estimated that about 1 million tests will be done within a 2 week, 2 month, I think, 2 month. And we are trying that. On the basis of that also, we will develop our further steps. Next slide, please. Because in COVID-19, the severity of illness, we know all, because it might be the asymptomatic. Previously in Nepal, it was more than 95% cases are asymptomatic, and most of the people, they used to tell, and the political leaders, they also used to tell, we have a great immunity, we have a Himalayas, that's why COVID can't infect us. But with the time, the cases are mild, moderate, and the severe and critical cases are increasing. And nowadays, because of the home isolation, also the cases of critical are more in hospital. Next slide, please. Next slide. Next slide, please. Yeah. In the management, whatever the facility, whatever the invention, and whatever the discovery are going on the world, we are following that also. That's why we are doing the supportive and symptomatic care, antiviral drugs also in early stage, and immunomodulating agent in the later stage. Next slide, please. In the supportive, we know, because most of the patient, we need to support by the oxygen supplement. That's why nowadays most of the COVID dedicated hospital and the COVID hospitals, they have a oxygen plant also, and all sort of oxygen therapy also, and they are providing the fluid management also. But in the fluid management, they have to treat the patient cautiously, because they should not underhydrate also and overhydrate also. And in the same way, the complications they are also managing, like in liver failure, renal failure, and other complication. Next slide, please. In the antiviral agents, even though WHO have told remdesivir doesn't have a significant value, but in Nepal we have also a trial, and most of the patients, they are getting the remdesivir and they are responding very well. In the same, I can say, because myself also, when I got the infected, I got treated by the remdesivir only. And similarly, the next antiviral is the favipiravir, then monoclonal antibodies. These all and other agents, ivermectin is also using based on the health institution and the patient's condition. Next slide, please. And the immunomodulatory agent also in steroids and others, they are all types of treatment. They are based on the physician's choice and based on the patient's condition. They are using, because in Nepal government, they have given the choice to the physician for the selection of the drug based on the patient. Next slide, please. But in nowadays, because when the first case was seen in the January 20th, in Nepal, when the patient came from the China, that is the Nepalese student, then in the almost in March, we have a second case. After that, the few cases are coming, but still in central infectious disease hospital, Teku, the follow-up of the same first and second, and those times patients are coming. They are saying that still I have a restlessness, I have some problem in the breathing. That's why these also coming a challenge to us to manage the post-COVID sequelae also. Next slide, please. Again, next slide, because I don't have to describe these things. And now, because of the long duration of the COVID, and the infections are also increasing and becoming the pandemic, we have shifted to dedicated hospital to the mixed hospital, because in the first beginning we dedicated the some hospitals for the level 1, level 2, and level 3 COVID hospital based on the management of the patient. Because if the patient is mild, then level 1 will do, and if the moderate, then level 2, and if it is the severe and multi-systemic, that is the multidisciplinary, then level 3. But the patient got the trouble, because when the patient is coming with the fever, or just for the sneezing, they are not taking the case, and they are directly shifting to the COVID hospital. They are sending to COVID hospital. That's why now we have made the all the hospital, they have a separate building and separate standard, so that in the same hospital also they have a different COVID dedicated ward or COVID dedicated hospital, and the remaining non-COVID service is also going on in the same hospital. And now PCR also. In the beginning, all the PCR, all the patients who want to do the PCR, who need to do the PCR, all were the free. But they have changed. But now the government have changed. Only the symptomatic patients, the PCR is the free. And the remaining, if the patient want to do, they have to pay. And in the similarly, the hospital isolation to home isolation, because when the infection is increasing, then there is a deficiency of the bed in the hospital also, and in the isolation center also. That's why we told for the mild cases, they have to they can stay in the home if the home allows the isolation standard. And in the same way we have shifted, and still if some patients they don't have the isolation standard in the home or the room or the community, then they can go to the government run isolation center also. And once the beginning of the COVID, this is the our opportunity also, because always the government used to give the much more fund to the structure in the road and the bridge and the other places. But because of the pandemic, we got the little bit more budget, and we have done the investment in the strengthening and the development of the hospital also, and in the same time the logistic also. And the treatment before was the all the treatment was the free, either that might be the billionaires or the uh, low income people. But now we change those persons who cannot afford the payment, then they are the free, and the remaining they can pay. And in the government hospital, that is the free. In the private, now they are not doing the reimbursement. The government is not doing the reimbursement. And similarly, we are doing the prevalence for the antigen and antibody based, and on the basis of that we will do the further action plan also. Next slide, please. And this is the last one, the rapid action plan, because that from the 17th October to the 12th February. Next slide, please. And we have estimated that if that is the moderate case scenario, the infected people will be the almost 148,000. If that is the worst, that will be the 300,000. Next slide, please. And the key content of the rapid action plan are the next slide, please. Next slide. The control of transmission will be the first one. Then the action plan is the test and treatment. Then regarding the COVID vaccine, because we are expecting the first vaccine to come from the COVAX, but it is becoming the late. And some Chinese companies and Russian companies, they are also in Nepal to uh, talk about the COVID-19 vaccine. And I think with the all storage capacity, then trial environment and others, the trial was done in India. That is AstraZeneca will be the first one to come in Nepal and to buy the Nepal, I think. That way we are doing. And next slide, please. The continuity of the essential health service, because once the COVID has started, all the essential health services are stopped or partially stopped, and now we have a main attention to maintain the continuity of the all essential health service, so that by the essential health service shortage, no one will lose the life. And similarly the logistic also we have to make the update, and in the quality also, all the things of what we are buying from the neighboring countries or from within the countries. Next slide, please. And the information management, because whatever things the government is giving, the people may not getting the all the information. That's why we are establishing the units, and we are using the national televisions and the national printing media for the information. And in the same way the reports and everything we are trying to manage by the information management unit and system. And similarly the next main thing is the risk communication. Once the patient get the PCR positive, how to communicate with them and with their family also. And similarly the governance and oversight we have in RAP. Next slide, please. And we have estimated the budget for the rapid action plan, and this is the total expenditure, and we have asked to the cabinet, and they have given the positive signal also. Next slide, please. And the government has request to the all the stakeholders. First thing is the breaking the transmission chain through strict application of the public health measures, because nowadays even though government has not allowed to open the cinema halls, theaters, but they are opening in their own risk. And similarly the some uh, schools also they are doing that way. And similarly the strengthening of case follow up through the toll facilitator team, because in every toll we have made our own team. They are taking care of the contact tracing and case investigation. And similarly the IPC and healthcare waste management for the all the health institution also, health workers also, and all the local representative also. And similarly monitoring and support, especially for the home quarantine and the isolation, because they are not following the standard and following the rule and regulation of the isolation and quarantine, because they are thinking that if I will isolate, or if I will become the positive, 14 days will be the loss for me, because my business will be lost, my contact will be lost. They are thinking that way. That's why we are using the monitoring and supporting for them in the toll. And similarly, the when risk communication and community engagement we are doing, because the local representative, which are the elected, and the local persons who are the volunteers, we are using them. And COVID comorbidities, including laboratory logistic, and the continuation of the essential health care is going on. That's why now no one is leaving behind the basic healthcare service and the essential healthcare service. Next slide, please. And thanks for Prevalence, and thank you all, because this is the experience from the Nepal, because we the COVID is a new disease and we are learning and doing everything.
Thank you,
Thank you.
Prakash, for enlightening us. The word Prakash means light. So, giving a light about Nepal to India. So, I'll come back to a couple of things. One is that you said, so let me first come back to the graph of Nepal again.
Yeah.
And I'll pick up the graph of Nepal again. And so I'll pick up. I want to pick up the graph of Nepal. Okay. So if you see here in Nepal,
Yeah.
we have a wave which is declining.
Yeah.
Okay.
Yeah.
And I would take it as a single wave.
Mhm.
because the first wave, if we see, and if we see the mortality rates
Yeah.
in Nepal are also higher in this because there was no mortality in the first wave.
Yeah.
So there is a mortality and the first wave.
Mhm.
And you said that there was 17% patients who were seropositive in September.
Mhm.
And in August 31st, India had a seropositivity rate of 7%.
Mhm.
And we also expected our seropositivity rate in September to be the same as 17%.
Yeah.
Because we don't have a second wave, and there is data that for every one positive, there were 30 asymptomatic in August, there were 60 asymptomatic in September, and there are 90 asymptomatic in November. So we are presuming in India, at many places, we have achieved a herd immunity.
Mhm.
Now, unlike Pakistan, which is showing a second wave, Nepal has not showed a second wave. Do you
Yeah.
think that Nepal is also heading towards a herd immunity because of asymptomatic infection? Because these are the symptomatic cases.
Yeah.
Okay, so do you have any data to say what is the ratio of symptomatic to asymptomatic cases?
Yeah, because in previously, I think before September, there was almost 95% cases were the asymptomatic. And generally, we are doing the PCR test only those who are coming from outside the country. And inside the country, we didn't do the such a seroprevalence or test also. That's why we are doing now to know that in Nepal we got the herd immunity or not, because
Yes.
still we are not sure.
See, why I'm saying is, if I see the prevalence of cases in Nepal, it is 8769 per million population,
Yeah.
and the same is 7335 per million population in India.
Yeah.
So per population, incidence of cases is the same in
Yeah.
India and Nepal. So
Yeah.
that means the graph is the same.
Yeah.
Graph single wave, no second wave hasn't come in India and in Nepal.
Nepal also. Yeah.
Our food habits are nearly the same.
Same.
Culture is nearly the same.
Same. Yeah.
Some or other, I feel that Nepal also may not get a second wave, and
Yeah.
Nepal also subclinically may have ended up into a type of a herd immunity.
Yeah.
If you cover 20% of your population with the vaccine,
Yeah.
you may be able to get rid of the disease in your country. That's my speculation based on my experience of what I am interacting with people.
Yeah.
Because but if you see, if I show you Pakistan on the other hand,
Hmm.
let me see Pakistan. So COVID Pakistan. If I see the Pakistan in the COVID, you can see in the Pakistan I have a. So if I go back to Pakistan, and I can see in the Pakistan there is a peak, and
Yeah.
that peak also is smaller than the first peak.
Hmm.
Therefore, I will not call it as a literally a second peak of a type which is happening
Yeah.
in UK.
Mhm.
So if I now want to go back to Bangladesh, if I go back to Bangladesh, which is also showing a pattern like Pakistan.
Yeah.
So what I personally feel is that all the countries which have a high density population,
Mm.
their zero prevalence may be much higher than what we are expecting,
Yeah.
and they will end up into a subclinical herd immunity.
Yeah.
And if another 15 to 20% of the population is covered with the vaccine,
Mm.
the second wave may not come.
Yeah. Yeah. That's why during the vaccine estimation also, there was a one query, because as you told, Dr. Agrawal, because if 20% population vaccine is giving by the COVAX, that might be enough for us to get the herd immunity.
Yes.
Then Nepal may not have to buy the further vaccine.
So what
There
will
is
happen is Nepal will come back to the same 20% Nepal government will pay, and rest 80 who wants it they can pay and take it.
yeah, that way also.
That the way you have done it for the testing only symptomatic. So
Yeah.
you may pick up 20 highly high risk people, 20 crore. Out
Hmm.
of two, you have 3 crore. So out of 3
Yeah,
crore, you need only 60 lakhs.
yeah,
That means 60 lakh people, if you cover with the vaccine, you
yeah,
may be able to get rid of the virus.
yeah.
That's what I feel. That's what I feel it. Even in India,
Hmm.
20% vaccination, rest is natural infection, and you take care of the whole thing.
Yeah,
So what is the? I mean, you are a advisor to the government. Is it
yeah.
a thinking going on that we want to give 20% of the population?
Yeah, yeah. Because previously, because the 28% peoples are the less than 15 years children, and
Hmm.
we were planning to give the 72% people vaccine. Yeah, because the less than 15 years, they are the 28%. They don't have that so much transmission. There is no trial in that age group, and the remaining 72, the government, the prime minister have told to all the Nepalese peoples will get the vaccine. He told
Hmm.
that way.
Hmm.
That's why we calculated on the basis of that the 72% people of Nepal will get the vaccine.
Hmm.
In 72, the 20% will be taken from the COVAX facility,
Hmm.
and the remaining 52 will be the 30% will buy by the government, and the remaining 22% will be the given by the international NGOs, yeah, agencies. Yeah, that way
Hmm.
we have calculated. And in later stage, when the seroprevalence the report has come, then
Hmm.
we have thinking that first we will take the 20% COVAX, the
You may not need.
remaining vaccine will be opened for the private sector.
Okay.
They will sell. The government doesn't have to buy the vaccine. That way we are thinking.
Okay. So 20% COVAX is your commitment.
Yeah,
So 20% of the population will come back with the COVAX.
yeah,
Okay, that's a good idea. That's a good way of looking at it. Government can save money out of it
yeah.
because 20% they already have invested, and
Mhm.
rest of the things you don't have to depend, and people can buy it. People who can afford.
Yeah,
Not a bad idea. Not a good set. Not it's a good way of taking it out a strategy with that. So let me thank you. And with the half an hour, almost 35 minutes are over. Let me thank you for coming and discussing. And I think I'm very convinced, and I'm very much surprised to see the mortality rate of only 0.7%. So Nepal has done very well. So 0.7% mortality probably is because of your younger population,
yeah,
which is predominantly in Nepal, and the elder population has not yet been infected so much.
yeah,
So, or maybe the water of Nepal is different and reducing the mortality, and the air and the water of
yeah.
Nepal is different.
Water, yeah, like a food
Yes,
habit and other things.
yes, good
Yeah,
food habits.
yeah.
So let me thank Dr. Prakash to be here with us, and that's all for today. We will be back tomorrow 7 p.m. with another show. Keep watching Med Talks with Dr. KK Agarwal. Stay tuned.
Okay.
Namaste and good night.
Okay. Good night.